morning, everyone. Thank you, Dr. Ahlawat, for allowing me to present the results. This is the robotic transplants that we have done till today after exclusion, and then we've compared this to the contemporary open cohort. So we all know it has been pretty well summarized that the benefits of minimally invasive surgery are well documented for most of the surgeries that we do. But spectacular advances have taken place in the medical management of transplant disease, and the only major contribution that came in from the surgical side was the lap donor nephrectomy, which has now become the standard of care. But the role in recipient surgery was not well defined, and whatever recently published reports we had for the minimally invasive surgery application in transplant recipients, they showed a delayed return of graft function immediately at discharge, as we all know right now. And we reasoned from this, we kind of tried to reason it out. If it was the absence of graft cooling, that could be the cause of the longer prolonged ischemia times. So putting everything in place, we tried to develop a technique that completely eliminated warm ischemia according to the guidelines of the ideal model. It was way back in 2002 that the first report of an initial case of a robot-assisted kidney transplant was published, where the graft was placed through an open incision, and then the vascular anastomosis were done with robot assistance. Several years later, 2 case reports followed subsequently. In 2012, Dr. Modi reported on a series of laparoscopic kidney transplants with excellent 6 months graft function. We all know that many years ago, Wickham showed that warm ischemia times of more than 30 minutes resulted in partial compromise of the renal function. He further suggested that probably the ideal temperature for maximum renal protection was about 20 degrees Celsius. So we were concerned that while on the learning curve for minimally invasive robotic transplant, the quality of the vascular anastomosis may be compromised during the learning curve, as the warm ischemia clock was ticking on ahead. Therefore, the entire attempt to cool the kidney during the ischemic phase of the transplant was initiated. This particular precaution, as we build up more on the number of surgeons, our experience grows, may not be required once the anastomosis time and docking time and the overall ischemia times get shortened significantly, but that will come later. Of the 3 major published data in terms of robotic renal transplant, which describes the various techniques and the port placement docking of the robot, except for our group, nobody has reported the intracorporeal graft cooling. This entire study was conceived and designed as per the framework of the ideal guidelines, started way back in 2012. We completed phase 0 by 2012 December. Phase 1 was initiated after IRB and Ethics Committee clearance in January 2013 between Medanta and IKDRC. Phase 2A data was published in January 2014. And during the transition from phase 1 to phase 2, the phase 1 initially comprised of initial 7 patients, and then subsequent 43 comprised the phase 2A. And the entire data, which I'm going to present, is about 79 patients from phase 2B. Now, what we've seen with the increasing experience is that the procedure has gradually evolved over a period of time. And we have seen that there's a significant decrease in the vascular anastomosis time and the ureteroneocystostomy times. If you look at the timeline of the evolution of this surgery, in the initial first 7 cases, 3 major things happened. The gel point, this vascular bed we prepared the vascular bed first before we started putting in the gel point port. By the time we moved on to the phase 2, the various evolution gradually started, that we started using the scalpel for the linear arteriotomy, using the aortic punch. And as it progressed to case number 25 almost, most of the things had been standardized by then. And more or less, we are following the same protocol as this is by case 25 till now. In this current study that we took between January 2013 to November 2014, 511 patients underwent renal transplant at our centers, out of which 82 did not fit into the inclusion criteria, which were because of pediatric population, atherosclerotic disease, and major surgeries, second transplant, immunological risks, simultaneous dual transplants. Now, the 429 patients that remained, they were all fit for robotic surgery. They were, of which 79 only consented for the procedure, and this was compared against an open cohort of 350 patients. We defined the primary and the secondary outcomes, primary being the post-transplant graft function, secondary the surgical and immunological complications, and perioperative parameters. All patients had a minimum follow-up of at least 3 months. A protocol non-contrast CT was done in all the patients who went into phase 2A. Visual analog score and analgesic requirements were used to assess the pain in all the patients. Now, if you look at the preoperative parameters between the two groups, they're almost comparable in terms of age, sex, and the BMI, the induction procedure, the Charlson's comorbidity index, and the ASA index. If you look at the operative parameters, look at the robotic group, and in terms of the operative time and the rewarming time, they are significantly higher. That was because of the initial learning curve plus plus waiting for the graft from the donor team to come in. If you look at the blood loss and the incision length, significantly lower for the robotic group, 146 as compared to 345 mils, and a 6.1 centimeter compared to a standard 15.1 centimeter incision that we use. If you look at the box plots for the operative outcomes, you would see that in terms of operative time, the robotic kidney transplant took a longer time. In terms of the ischemia processes, in rewarming and the total ischemia times, the robotic group was higher for obvious reasons. For the vascular times, again, the vascular anastomosis took us a slightly higher time in terms of arterial and venous anastomosis, and the uretrovesical anastomosis as well. The open was faster. But if you look at the post-operative pain score as termed by the VAs and the analgesic requirements, the robotic group showed a significantly lower pain score as compared to the open group, but this usually is stabilized by the 4th day. If you look at the fall in the creatinine levels, within the first week, both of them had comparable creatinine, which almost continued the same till about 3 months. If you look at the analgesic requirement, the epidural, all the open patients had this, most of the open patients had this epidural catheter placement for pain control, and yet they required, the robotic group required a lower analgesic requirement as compared to the open group, the one on the extreme left. If you look at the complications, now this is a spider plot wherein all the complications have been put along as far as the numbers in the face of a clock, and the spokes are the complication, and the web that is around it is an increment of 5% value. So if you just visually compare, you can see the percentage, the open kidney transplant had a higher complication in terms of the graft biopsy, graft loss, graft rejection, as compared to the robotic group. But then this has to be further substantiated with longer studies. So we could do robotic transplant as for the group also proposed for obese patients. We had smaller scars. There were no wound infections in the robotic group, no lymphocytes were rotated in the robotic group. This is a CT of a patient who underwent an open transplant, which was 22.3% of lymphocytes in the open group. So in conclusion, robotic kidney transplant with regional hypothermia is safe and reproducible. Graft and patient survival are comparable to open kidney transplant. Regional hypothermia in our series has helped avoid delayed graft dysfunction. Benefits of minimally invasive surgery were extended to the recipient. There was significantly less perigraft collection with trends towards lower infections. The limitations to this study was that it's a small number, single institution, and a single surgeon. The groups were not matched, and it's a comparative study. So where is the future? The next step in the development of this procedure is we need to have a comparative analysis of outcomes of the open kidney transplant and robotic kidney transplant in matched patients. More centers and more surgeons need to do add to this series. There has to be an evaluation of the learning curve and obviously a prospective comparison with the open kidney transplant group as per the ideal recommendations. Thank you very much for your attention.